the people about those who have who try to persist with non-cuffed, non-tunneled catheter beyond say 30 days or so, even in AKI or CKD. I mean, I'm sure you as well as Valentine see a lot of patients coming to us who have had catheters for 4 weeks, 8 weeks, 12 weeks, non-tunneled catheters. So, would you like to give a message to people
Yes,
about this?
definitely. We know the infection rates are pretty much high with non-cuff catheters, and the chances of vein stenosis are again very high when we use non-cuff catheters, because the stiffness of the material, yeah, increase risk of infections. And especially it is also not comfortable for the patients to go out with a sticking catheter in the neck and having dressing all around. So it is not comfortable for the patients also. And especially when we try to keep them on OPD, so it is always preferred, whenever we are sending even AKI who are not recovering, on an outpatient basis they should be changed to the tunnel catheters.
Perfect. Yeah. Thank you. So, Valentine, so what is the time duration to up to which you can keep this tunnel catheter, number one, and then what would be the standard operating practice so that we can get maximum dwell time? So basically, what would be the care and maintenance of this tunnel catheters? What are the do's and don'ts?
Yeah. So your first question, what is the time that we can keep the catheter? So median time, when one looks at international literature, they say 18 months. When Dr. Sampath Kumar and I published in CKJ about 6 years ago, it was in our hands, it was about 11 months. Now that has improved to about 14 to 15 median. My longest surviving patient, he's right now also on dialysis, is 7 years. He started as a child, he has moved up onto adulthood, and for 7 years he is with a tunnel cuff catheter because his growth in childhood was hampered and he had two failed fistulas, and there's no possibility of getting him an AV fistula. So he's still with a tunnel cuff catheter. So we do have, and I'm sure you have also such patients who have lasted with tunnel cuff catheters for a long time. Having said that, I'm not encouraging one to avoid fistulas or to give up on fistulas. Fistula should be the first choice. Attempts should be made for fistulas, for grafts, for saphenous vein grafts if necessary, and one should not be content with having a catheter or be proud of keeping a catheter for a very long time, because ultimately that's not the aim. The second question was, how do we optimize the life of the catheters, the do's and don'ts, and what do we do for care? So adequate heparinization is essential. You stress the point that one has to read the amount on the cuff of the on the hub of the catheter and fill the catheter lumen plus zero point 0.1 for some amount of diffusion which occurs. Now that's easily done with upper limb with IJV catheters. There, most of them, right side, left side, it's between 1.5, 1.6 to 2 ml of heparin that's required. When it comes to a femoral or an IVC catheter, those long catheters, the amount required is 3.2 ml of heparin per lumen. So 2 vials of heparin are required, and it's fine when we insert the catheter, but the nurses doing dialysis need to know that each time they will require 2 vials of heparin to lock the catheter there. And if they don't have that and they don't feel like asking the patient to pay for an extra, then what they do is to dilute the heparin, 5 ml, add 1 cc of saline, and you have inadequate heparin pushed in. And that's where the problems with the catheters start. The second thing, of course, is meticulous catheter care to prevent infections. So the CDC scrub the hub protocol, it's given in the ISN guidelines as well. The 5 moments of hand hygiene, CDC's 5 moments of hand hygiene when handling a catheter. The scrub the hub protocol, ensuring that catheters never remain open to air at any time. When the caps are off, the catheter should be wrapped with a chlorhexidine soaked swab or a betadine soaked swab. We wrap the joints of the dialysis line and the catheter with a chlorhexidine or a betadine soaked swab. Try to limit the infections as much as possible. We use triple sporin ointment, which is the CDC guideline again, and because in India gram negative water organisms seem to be the commonest cause of CRBSI, so CDC recommends triple sporin, and that's what we use, neosporin ointment at the exit site, transparent dressings, and change the dressing whenever it is soiled or wet. We prefer chlorhexidine for catheter cleaning and for exit site cleaning. And one of the advantages of chlorhexidine is, in addition to, of course, studies that show that it has the best antibacterial potential, is that it does not stain catheters. So betadine stains a catheter, and sometimes it is not possible to say whether a catheter is stained with betadine or blood, whether a dressing is soiled or it has a betadine stain on it. So it will have to come off in this situation. K. Doki says that catheter dressing should be changed at every single dialysis. We don't do that because the less handled the catheter, the better. So we would change them once a week, and a catheter dressing appears to be non-adherent whenever it appears to be soiled, whenever it gets wet in such situations. We advise patients that during the first 15 days, they should ensure that the dressing and the catheter is not exposed to water at all. And frequently have this question, what about bathing? What about other things? So in the first 50 on, absolutely not. After that, if a patient wants to bathe, now sleeves are available. So you get a sleeve with an adherent like a colostomy bag, which can be put over the catheter, and it adheres to the skin. So the catheter and its exit site are completely isolated. So patients can bathe, shower, or swim in such situations without a risk of the catheter getting contaminated by water. And of course, checking from time to time. So we would like to know about what are the venous pressures, what are the flows being obtained. I insist that when we use pre-pump lines, that the arterial port be transduced as well on the dialysis machine. So we would like to know what is the negative axis pressure for a particular blood flow, and if we are seeing increased axis pressures being required to deliver the same blood flow, then those could be early signs that a fibrin sheath is beginning to form. And if a fibrin sheet is present, then of course to take care, to do an imaging and take care of a fibrin sheet as quickly as possible. We used to use thrombolysis for catheter salvage. Unfortunately, urokinase is not available recently. Streptokinase can be used once, and then you have to wait for 6 months before you can use it again. Tissue plasminogen activator is too expensive to use routinely. There is one study, I've forgotten, maybe Hemant or Hardik would remember the name, which used a once a week, midweek thrombolytic lock with the other two locks being heparin to ensure to improve catheter patency, and that study also showed a reduced incidence of infections. I can't exactly remember the name of the study. It was a randomized trial which was published in NEJM somewhere around 2014 or 2015. So that is what would be my do's and don'ts about a catheter.
Thank you for this exhaustive explanation. But I'll tell you, Valentine, something. See, that study which there has been a debate whether you should lock the catheter with heparin of 5,000 unit per 5 ml or 25,000 unit per 5 ml. So these are the studies where they
Right.
use 5,000 unit per 5 ml, and
Yeah,
that's why they need more of this altiplase or
thrombolytic.
retiplase or whatever thrombolytic agents. They are exorbitantly expensive.
Exorbitant.
Another thing in our country, like in between how Ufrec 5K was available, which
Yeah,
has gone off the shelf,
gone off the market.
abroad,
Yeah,
they have RTPA available specially for
1
dialysis
milligram.
catheter,
Yeah,
or one, whatever,
one
1 or 2
milligram.
milligram.
Yeah,
Yeah, one. Yeah.
yeah,
So somebody has to take this clue and come out with this.
yeah,
Maybe
yeah,
Bard can take
yeah, yeah.
initiative
I
on
think
that.
so.
Yeah.
I think, Hemant,
So
that's
that
a
is,
very important point. If these
yeah,
people are making catheters, then we will need to have what is required for catheter care as well. I'm waiting.
yeah.
I've not met that Bharat Serums guy. I'm very puzzled why they removed
He's
Ufrag from
stopped
the
coming.
market. Yeah, once that Ufrag
Yeah.
5000 has disappeared. So the people
So
who
that
are
is, yeah.
making catheters perhaps should take that to give us the chemical. Citrate was available when it was Duralock citrate. It was a great this, but
Hmm.
the later citrates were useless. We didn't find them
Yeah.
useful, so we've given up citrate.
Yeah.
Though the
And
literature says 4% citrate is good.
yeah, Hardik, you want to say something?
Yes, just adding to the what Sir said about the catheter care. We I always insist our technician that there should be two set technician at the time when they are using catheters for a connection and disconnection. So the person who is handling the catheter should not be touching other surfaces. So for
Yeah.
Yes.
our unit, we have make sure that two technician are must when they connect disconnect the tunnel catheter. For fistula, one is okay.
Yeah.
Yeah.
One more
And the other
point.
thing which we,
Yeah. 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 Go ahead.
yeah, which we do is to, when they are heparinizing the catheter, to ensure that they give a continuous pressure on the piston while clamping the catheter. Sometimes if that pressure is released, blood backflow happens after the injection of heparin, and then when they clamp, there is blood already in the lumen of the catheter, and that leads to clot formation. So we insist that you push and keep a thumb piston till the catheter is completely clamped.
Yeah. Yeah, Hardik.
Yes, another thing for the femoral catheter, because when on weekends the dialysis they gets a lot of blood coming back in the catheters. So sometimes I tell them, if you are able to see the blood visibly clearly at the in the catheter, you can additionally heparin lock, preferably at in hospital, otherwise at home also.
Yeah,
Okay.
thanks. That's a
At
very
home too. Yeah.
good point.
Yeah. Very good point. One more thing I need to emphasize on is, which I have always, and the life has become in that sense easy for me because of COVID, is that when the catheter is opened or handled, the patient and the operator should be wearing a mask. So in
Mask.
the pre-COVID era, it was like, you have to force somebody to wear a mask, especially the patient. But I have always insisted on that. And even if a relative happens to be around that patient during start or closure of dialysis, he is also insisted that please wear a mask if you want to stand inside. Of course, with COVID era, that has become
That has
a
become much
norm.
easier.
So, yeah, so much easier. We don't have to break our head on that point. And number two, about this uh, Tegadam CHG. So I would like both of it. So it's costly. It costs almost 900,000 rupees. So it comes. It's a Tegadam which comes with a pad which is chlorhexidine
Chlorhexidine
impregnated.
impregnated. Yeah.
Yeah. So what do you feel about those things? You have no
No
experience.
experience.
Yeah.
I've
We
read
have
about it.
routine.
No experience.
So 70 to 80% of my patient who can afford, we have changed them over, and just to cut the cost there, we routinely change it once a week, because every time changing will become a bit too much, 1,000 rupees every dialysis. So but many of them are very happy using it once a week. And that uh, we are just going to be auditing our results of last 1 year of CRF BSI, compared to the previous year. That auditing process has just started a few days ago, and maybe I'll come out with the result of, because we made certain changes in the catheter handling protocol, and we have, I mean, roughly I can say we have seen a drastic reduction in CRBSI incidents, but I'll come out with those figures sometime later in the day. Okay, so we move further on to so Hardik, actually both of you can answer this one after. So Hardik, please tell us about what are the various catheter tip designs of these tunnel catheters, and how does symmetrical tip catheter get placed in today's world, and what is then the role of glide path compared to other competitors in the market?
Okay. So, going it to one by one. So, first, will be what are the different designs we have been using in the past, and what are available, and what are the advantage of each other. So, previously we have a step tip which was commonly used because of the cost of the previously only symmetrical tip was palindrome. So, the cost of palindrome was quite high, so we were using step tip. And then when the BARD came with a split tip, again because of cost reason we started using split tip quite a bit. The problem of split tip was when you required to change it. There was a big problem because you have to remove the catheter, you can't change it over wire. Sometimes the one tip will get stuck in some area of vessels, and there was significant number of increased venous stenosis because of the step tip what we have observed. So nowadays it is always preferable to go for the symmetrical tip. And the, as you pointed out in the your presentation, step tip, one of the lumens, if especially on the, if you are putting on the left side, one of the lumen will get pushed against the venous wall or arterial at right atrium wall, and then that there will be keep on that flow problem will keep on arising from one lumen when we were using step tip. So in today's time, I think symmetrical tip is the way to go forward, comparing all other previous catheters.
So,
Uh,
Valentine, where will you place? Can I ask Valentine to answer this question? So, where will you place
Yeah.
Glide Path versus the other brands which are available in the market?
Yeah, I mean the cost is lower and it's possible to insert over a guide wire. So I would use, as Hardik said, prefer symmetrical, because studies have shown that there is in fact a reduced recirculation with the symmetrical tips. At least that study was done with palindrome, and there's no reason to believe that any of the others would be different. So symmetrical tips, actually because of the design of the catheter, have been shown to have lower recirculation than the step tip. So step tip, I was quite happy with step tip when I used to use them, but of course if a symmetrical tip is available, especially for the left side, I would use it. I did not like split catheters earlier, and like Hardik was saying, with the split catheter, as it traversed last curve from the left side, one lumen would go up into the right IJV, and one lumen would go to the right atrium. So what I used to do in those days was to put two guide wires. I used to put both the guide wires, let both the guide wires go down into the IVC, and then thread the split catheter over both guide wires so that it went into the right spot. So symmetrical tip removes some of those disadvantages. So left side, I would certainly like to use a symmetrical catheter. Right side doesn't make too much of a difference. But yeah, also then you are sure that both the tips are placed at the same level, which both of you have already stressed. When you have a step tip, then one tip is fine, it's in the middle of the right atrium, and the other, during when the patient moves his arms, might come up into the SVC. So that is an
Yeah,
additional advantage.
thank you. No, so just to give just 1 minute, Hardik. Just to give a further update, uh, SIDA controversies in dialysis access got over last weekend. It was on last Saturday, Sunday, and during that conference, BARD has introduced a new catheter. It's called Pristine. It has symmetrical tip which is in the Y shape. I don't know how would that be. No, it's a small Y. I mean, not the split tip. So there is a Y right at the end. So it's still symmetrical tip but separated by Y. Now, how does it perform? Let them bring it to us. We will try and use it and see. Just an update. It's called Bard Pristine. Yeah, Hardik, you wanted to say something.
Especially I will prefer this bar catheter over others when the patient has repeated history of punctures, because the catheter bar catheter glide part is stiffer than the others, and it is easy to insert over the wire when you want to complete on the, especially on the left side, when we want to do catheter only exclusive on the wire, when the sheath, because of the tortuosity or because of the previous problems, we were not able to insert the sheet full in the full depth, then it is preferred over others, because it is pointed and it is quite stiff than other compared to others, so it is easy to insert over the wire.
And one more
I
thing is
think
that, yeah, Valentin, yeah,
Yeah, no, I think what Adik is saying about the left side and the sheath, that is a very valid point. You have to insert the sheath with continuous fluorovision during that time, and you have to ensure that you are straightening the vein actually with your manipulation of the sheath to make sure that the sheath goes in the right position. So with here, with the wire going through, and when you insert the wire over the catheter with the stillet over the wire, it saves you that reason of needing two wires also. So over a single wire, both the lumens come together, and it is a big advantage.
see, the other advantage of this glide path is that it already comes with one small tube which is inserted into the arterial end, and it is adequate enough to allow the passage of the wire through it. So, and that's a stiff. So to if you want to make your catheter more stiffer, you put that in and thread your wire
Let's still it.
through that. Yeah, the still, so that
Yeah.
your especially while going from the left side, it becomes easy.
Yeah.
Now, having said that, uh, Valentine, so how would you be with this stilet being available? Would you still prefer to put the catheter with sheath, or you would prefer to use sheathless technique?
On the left side, I would prefer sheetless. On the right side, I'm very comfortable with the sheet. And left side, if I have to insert, then as I said, I want continuous vision so that I can visualize my sheet. A lot of manipulations I have done on the left side with the sheet,
Mm,
which, as Hardik said, sometimes the sheet simply won't take the curve. You are not able to straighten that vein to adequate. Then I have to pass the sheet just up to till it goes inside the vein, leave the guide wire in place, and use both guide wire and sheet together on the left side till the
yeah,
catheter enters the vein, then let it thread over a fairly stiff guide wire and
mm,
peel it out at the last minute. So a lot of manipulation may be saved when we can use the stiffening stillet.
mm, yeah.
So left side,
So
that is where I would like it.
so all of us have had difficulties placing the catheters in the left IJV, right? So, Hardik, I mean, is there a learning curve for everybody when they start putting the tunnel catheter? They start with the right IJV, then they come to the left IJV, then they come to a situation where there are redos, second redo, third redo. I mean, two, three non-tough, non-tunnel catheter, and now you're going to put a tunnel catheter. So, how does one learn and evolve?
So I have slightly changed myself in last few months. Actually, if you remember, sir, I have sent two patients of a left innominate brachiocephalic stenosis, and it is quite common on the left side. So now I have changed. If the right side fistula is not going to be possible, I will prefer to go right IJV followed by right subclavian instead of going on the left side. If it right side fistulas are not going to be possible, because left side invariably the stenosis is going to happen if they remains longer on catheters, and if the left arm fistula is quite possible, I will still prefer right subclavian over left IJV. That is one thing. And as over the time we have learned that left side should be always be on the over the wire catheter. It should not be only sheath, because sometimes you immediately your catheter can go anywhere. So it is always preferred to put over the wire. Now with a good sheath available and with good valves, the bleeding is quite less. Otherwise, previously there was a bleeding used to be quite problematic, and sometimes we ended up without inserting a catheter. So with a good sheath available, it is always sheath plus wire whenever possible. If it's not possible, wire is always must on the left side. That is what we have learned over the years.
Yeah.
Pediatric catheters
So,
still don't have a valve on the sheath.
Yes, that is
They're still
biggest problem.
valveless sheath. Yeah.
yeah. So, how do you then? Okay, Valentine, give us your experience about inserting the tunnel catheters in pediatric age group.
Yeah, I've done a fair number of them. We have very good. In fact, it's very distressing, I would say, overall, that I have inserted so many, because it means that we are not making fistulas in children. When I listen to speakers from, because our pediatric unit has a tie up with Great Ormond Street, when I listen to Dr. Ruxana Shroff and so on, they talk about how one must make fistulas in children, but almost no patient in our unit has a fistula, very few of them, and most of them. So we are inserting a lot of pediatric catheters. I insist on GA. That is one situation where I don't even try. I don't want a struggling, screaming child while trying to insert. So I do it under GA. And yeah, the biggest problem is that the Maurkar catheter, pediatric catheters, they were the only ones who were making pediatric catheters, the 8 French catheters for a long time. Now MaxFlow is also available. I have not used it as yet, and those catheter sheets did not have a valve, so there was a lot of bleeding. So I always in those situations also prefer to keep the guide wire in place, because if there is, as Hardik said, a lot of bleeding and then you end up having to pull the sheath and so on, and then you have nothing in place. So in that situation, in pediatric, I retain the guide wire and I use both sheath and guide wire together, because in any case, the purpose of removing the guide wire when there is no valve, it doesn't serve a purpose. The valve is, when there is a valve, the guide wire is keeping that valve open and allowing air to enter. But when there is no valve, it is preferable that in all pediatric cases, I would keep my guide wire in place in such a situation. Otherwise, no real problems. We've had catheters, pediatric catheters functioning. As I said, I've got one patient who started dialysis as a child, is now 21 years old, and he's had his catheter for about 7 or 8 years. So we are still using. He's had two failed fistulas and is not anxious to go. I've offered him a saphenous vein graft with one of our surgeons. He's not anxious to go for it, but we keep trying to
So
push them.
what? Yeah. So one of the problem to overcome with this valveless sheaths, especially in the even the adult original Mahurkar catheter had, which
Yeah,
was oval shaped catheter,
perm cath.
not
Yeah, the oval
yeah,
one. Yeah,
yeah, yeah. So they had no valve. So again, same problem. We faced it earlier, learnt it ourselves, though it is not mentioned anywhere. So what we then started doing it is keep the wire in, but as soon as the sheath goes in and as soon as your dilator comes out from within the sheath, put an artery
put a
clamp.
thumb.
No,
Okay,
artery clamp, just an
artery
artery.
clamp.
It,
Okay,
I mean, we feel it will be traumatic, but that way these sheets are quite resilient.
yeah,
They don't tear so easily. So put an artery clamp, and then somebody has to coordinate. So now you bring the catheter in, and you just bring it up to where your artery clamp is, and then remove that. Somebody opens the artery clamp and push the catheter. Once it goes in,
that's it.
your bleeding stops because it is just
Stops.
occupying
Yeah,
the
yeah.
inner lumen. So that is one uh, modification which we have adopted, and with that we are very comfortable. Hardly any blood loss, less than 5 ml.
Okay.
So that's something
Yeah.
which we can. Yeah. So I think we have covered most of the aspects of this catheter. And if anybody wants to make any other comment or anybody has questions, please, Nikita, you can see the
Yes,
chat. Yeah,
I'll
Hardik.
I'll help
Yeah,
with the
one.
chat box.
By that time, Hardik, you wanted to say something?
Yes. One thing what we commonly say to patient is they use term permacath. So they
Hmm.
understand it's going to be permanent. So
Yeah.
and we always been asked question ke how long it can last. So I always tell them it can last lifelong, but infection you have to remove it in a week also, and don't consider this as a permanent catheter. It is a catheter which can last longer, but it's not a permanent catheter because we are now used to say it permacath, and they also consider this as a going to be permanent catheter. So now we have stopped
So
using the term permacath again and again to the patient. We said it is only the catheter which can last longer than the other ones.
We
yeah.
should
So is
completely do away with that term, because actually Permcath was the model from
not
Maurkar.
brand name. Huh?
Yeah, brand name. The correct name is
Hmm.
tunnel cuff catheter.
Hmm. No, no,
And the
and
dialysis
you have
technician, they
Yeah,
always tell the patient that get sometimes we get a patient referred for a insertion of permacath, so they says ke, get a permanent catheter insertions done, so they think it is permanent.
no,
perm.
no. So you just add one last sentence to when you explain to the patient that nothing is permanent in life. So
Yes, sir.
just say that,
Yeah.
then he understands what you mean. Yeah, Nikita.
Yeah, let's move to the question answers. I'll invite Rohit Salunke, Regional Sales Manager, BD India, to moderate the questions. We have few questions. We'll take the important ones, and rest of the questions, if need be, I'll send the details and get them answered for our delegates, because we've crossed the time. So over to you, Rohit. You can pick up few questions and let's get them answered.
Yeah, yeah, yeah. So, am I audible, Nikita? Can you please confirm?
Yeah, you are audible and visible. We can start.
Yeah. So, thank you, Dr. Mehta, for the great procedure video presentation, and also thank you, Dr. Lobo and Dr. Patel, for the insightful panel discussions. Most of the questions have been covered in the session itself. Um we have got a lot of questions from the delegates, and we have only few minutes left. So I will try to take as many questions as possible. So, Dr. Mehta, I will ask questions now. You may choose to answer the questions by
Yeah,
yourself, or you
others
can pass
panelists
it
can
to
answer. Yeah, yeah, yeah.
Dr. Lobo or Dr. Patel.
Yeah.
So, how is tunnel catheter better than AV graft in case of planned vascular access?
Valentine, you can
It's
take
not.
that. Yeah.
Yeah, no, it's not better. When one looks at the data and there is huge data available, the risk of dying is highest with catheters. The risk of infection is highest with catheters, followed by it's lower with grafts and it's lowest